And today we'll be focusing on people, practice, and culture. And we will start our first session, which is building competence for safety, advancing practice through education, research, and continuous learning. And to be able to moderate for this session is someone that needs no introduction, a familiar face to this podium. So I will not read the very many things that he has done, but just invite Dr. Boniface Mativa.
Thank you, Mildred. Good morning. I'm really happy to see a full house again. Yesterday was a very exciting day. I think Victoria and committee had given us quite a mouthful. We stayed through up to 6 and nobody complained. Today, Soderland has warned them they must not pull that one. So we are hoping to manage time very well. So we switch on to some conversations. And like Mildred said, today we want to have conversations around how we can advance patient safety, staff competency, and practice through medical professional education, both nursing and physician education, research, as well as collaboration between societies, specialists, as well as regulators. And today we are really honored to have very, very eminent persons to take us through those. So there will be 3 sessions, and then there will be a session on research, a sub-session on research, where we'll have 2 presentations. In the first session, we will have a conversation with one leader of a professional association, a specialist, as well as a leader from a regulatory body. In the second, we shall look at medical and nursing education as a catalyst for safe care, or quality and safe care. And then we shall, of course, go into evidence-based practice, particularly within the realm of nursing. In the first sub-session, we are honored to have Dr. Simon Kigondu from the KMA. And Kigondu, again, has a very, very rich heart of achievements and participation in patient care and health care. But I just want to highlight perhaps 2 or 3 things. One, he has practiced medicine for 25 years, from an MO through to an OBGYN, and later on becoming a healthcare executive in his own right. He currently sits here and will be in this panel in his capacity as the president of the Kenya Medical Association, which I hope many of us are who are physicians. But along with that, he's also a board member of the COGS, the Kenya Obstetrician and Gynecology Society. As you can see, he brings rich experience in terms of professional association. And of course, he does share a lot of other things, from being a technical advisor to the Association of Professional Society of East Africa, being a board member of Amnesty International, being a certified mediator, and many, many other good things. Kigondu, please come forward. Along with Dr. Kigondu is our very own Dr. Susan Wamithi. And Susan has equally a rich resume, and I just want to indicate what brings her along. Susan is one of the few developmental pediatricians, a new subspecialty, and she's very, very highly sought and does a lot of work. And as a subspecialist in developmental pediatrics, she has really proven herself in our local area to the point, local space, to the point of becoming an assistant professor at our medical college in Aga Khan. She chairs the East African Academy of Childhood Disability. She contributes to the WHO package of interventions for rehabilitation and for neurodevelopmental disorders. And for the pediatricians in the room, if you look at the Nelson textbook of pediatrics, the 22nd edition, she has actually made a contribution in a chapter on global child health section. Please join me in inviting Susan. Last but not least is the one Mildred referred to as Baba, Professor Were. Fred is not new to us, and he's been many things. He was my teacher and a teacher to many of the physicians in this room, from those who are GPs to those who are pediatricians, and to those who finally subspecialize like Nikita, to neonatologists. Prof. Were comes today in his capacity as chair of the KMPDC, that is the Kenya Medical and Professional, Kenya Medical Practitioners and Dentists Council, which is our regulatory body. But he's been many other things. He's been dean in the University of Nairobi School of Health Sciences. He's been principal in the same school. He's been professor for neonatology for a long time in both the University of Nairobi and at Aga Khan. And he has been part of our medical staff for many years. And we are really honored for him to bring such rich experience and to share his insights on the same. Fred, please come forward. Good. I hope we all have mics. Yeah, and they are all working. I think to lead this conversation, I'll start with the lady first. Dr. Wamithi, give us an insight into what developmental pediatric practice is and its place in quality and safe care for the small persons.
Thank you very much, Dr. Harry. So developmental pediatrics is a relatively new subspecialty. So we see children with disabilities, and the goal is improving function. And the interventions that we do is to ensure that children with disabilities optimize their developmental potential. And it really is a family-centered service, because you cannot optimize development up to the age of 18 without having families involved and educating them. And so one of the things that happens is that just because of the stress of having a child with a disability, we have our parents unfortunately being informed that there is some special treatment somewhere. We have some gene therapy that can change the Down syndrome, or we can change the cerebral palsy. And a lot of work is being done in research in trying to find treatments that can make change. But the safety part comes in is that we always see in pediatrics that a child is not a small adult. So the things that are being offered are experimental. And so one of our roles is to educate families as to what is evidence-based, educate families as to everything that you put in your child's mouth is going to go to the liver, is going to go to the brain, and not get over-the-counter complementary medications that can affect a child's development. And so our role is really multidisciplinary. We work with a lot of subspecialties, and we really try to provide a medical home where a parent is taught about the safety of the interventions and how to maximize the potential.
Thank you. And how big is the problem in terms of developmental issues for neonates? So much so that we can then use it to mirror on the quality of our perinatal services, both obstetric as well as neonatal.
So and I'm glad that Dr. Kigondu is here, because when we talk about developmental outcomes, they actually start from preconception. That adolescent who is starting to take alcohol, is smoking, and risky behaviors, those habits go into young adulthood. And with those high risk, whether someone is taking alcohol when they're pregnant, it will affect developmental outcomes. And so it's really important for that aspect of the preconception care, what's happening in the antenatal services, and I'm glad the nurses are here to talk about those medications that we're giving the patient will affect how a child develops. And then neonatal preterms, unfortunately, are at risk for developmental disabilities, whether it is cerebral palsy, autism spectrum disorder, some even ADHD. And so it's really important that we provide that safe medication, that safe environment that Dr. Nikita has talked about, and ensuring that those who are at risk, we see them early. A child with an ex-preterm needs to be seen by the developmental pediatrician as soon as possible, and Dr. Nikita and myself really coordinate those services. So for good outcomes, and remember that what happens in childhood has a long reach into adulthood. So the things we're doing in the neonatal period in ensuring good outcomes in delivery, ensuring post-delivery care is optimal for this child, will benefit the country eventually.
Thank you. And to Dr. Kigondu, in view or within the space of professional associations, medical professional associations, to what extent then? Because if we are talking about developmental pediatrics being a new specialty, close to over 60 years since independence, to what extent then can professional association help to identify, support, and integrate new and relevant specialties to enrich the healthcare space, particularly in terms of enhancing quality and safe care?
Thank you very much. What you said in my introduction, usually he skipped my most important introduction, which is that I am married to a nurse.
I knew you'd bring that up.
I have 25 years of nursing experience. Secondly, I would want to thank this forum, and the discussions have been very rich. The other thing is that maybe I'm here because I was born at the Aga Khan 50 years ago.
Wow.
I'm the only one who was born by cesarean section from my mother of 4. So I had a big head. I think there are two levers for what in this safety aspect. There are two levers for strengthening what we are discussing. And the first one is clinical practice. New specialists do bring fresh knowledge, enthusiasm, latest training. I can tell you 25 years ago, I was the medical officer, gynecologist, fetal maternal specialist. We used to do everything. I think we were close to God, by the way. I interned in Machakos District Hospital, and I knew everything, Now I've been relegated to a generalist gynecologist, because the fetal maternal, you send a gyne onco, you see, and that's development, yeah? So they bring fresh knowledge. CPD, the existing practitioners need to continue with CPD to remain relevant, competent, and adaptive, and to align with evolving standards. You have heard of the gibberish of the new,
Developmental practitioner.
That one was not there. And therefore, the role of new specialists is to bridge the workforce gap, which is on these things, to infuse new knowledge. There are things that you may think are obvious, but when you have people who have studied it a bit more, then they bridge that new knowledge. And they also encourage research participation. Some of us who have worked in the field for long may not have a chance to do research, but we are happy that the Aga Khan is bridging that research gap. And for me, my future would be to see the county hospitals, for instance, integrated with the university hospitals, so that research can be perpetrated. And I'm happy that, for instance, Dr. Supatunje, who was here yesterday, is a county worker. So you are able to take that knowledge that you have here. And then the role of professional associations is to provide continuous professional development platforms for them to be able to give to the wider audience. So that I think the associations have a role in propagating these new specialists in CPD platforms. Thank you.
Thank you. Prof. Were, in terms of the regulatory framework, how then would regulatory agencies like the KMPDC enhance the support and improvement of practice that would then impact quality and safety, particularly in pediatric and neonatal care?
enhance and improve.
Yes.
Thank you actually for this invite. This is my first official what's that road called again? The one opposite the Chinese embassy. All my work outside of the Devolution Conference has been confined to those rooms. This is my first external appearance to talk about the things we should be doing, that we may not be doing. But regulatory organizations, bodies like ours, whether you call it a council or a board like the one we were with Lukoya some years ago, have one fundamental role to protect the patient. What are you protecting the patient of? To make sure they are looked after safely and in a proper manner. To also protect the medical practitioner or the nursing practitioner or the dentist in a way to make sure not only do they do what is right for the patient, but what makes them safe as well. It's not in our interest that we are having lots of work in arbitrating or fining or pushing the practitioner whom we govern to go to court and get jail or pay fines, because we are thrived by their annual contributions. So it's in our interest that they stay and are alive to those contributions, and I speak for all of them. From that, I'll divert a bit, because we are talking a great deal about knowledge as being the pillar of good practice, good quality practice. When you invited me to this, I asked PubMed, which is the standard place to find out the knowledge, what's the relationship between, what's the impact of, I asked it in very many ways. Do CPDs enhance good practice? Not much. I'll disabuse you of that belief that actual CPDs, as they are done, what drives good quality care is the practice itself. It cannot be gauged by the CPD. And as much as CPDs are good, one of the revolutions I'm trying to do, if I can last the first term these days in Kenya, is to allow the CPDs to continue, but you must migrate, because the essence of regulation, the proper quality of care governed by the what we call the building block called the healthcare delivery, which consists of delivery, infrastructure, and quality. The quality for which, in fact, even this country is trying to create a separate organization, like a regulator to oversight, cannot be effectively measured by going online, which I sometimes send my grandson to enjoy the talk for me, and I don't think he gets to tell me what he has had. We have to find a way that we actually audit practice properly for the year, so that when the document comes in front of me, that I should think that our Professor Atwoli Lukoye should be permitted to continue practicing psychiatry. I don't think I should be using the fact that he has attended one big conference, which can give you the 50 CPD points. Me who attends some, like I'm sitting here, we're going to give you very many, but what I'm doing here has nothing to do with the neonatology in that sense. Nikita has title of that because she has spoken neonatology. But what she has said here itself does not tell me that she's intubating as well as when I taught her to. So to measure that, we have to be very critical. And I'm building up to the fact that yes, regulators must regulate. Yes, the CPDs should go on because people need to translate that knowledge into practice. But we have to get the indicators for the practice itself. Somebody is. If it goes my way, it may not, or may it be cut short. The one I want to hear telling me that you're practicing well, I'll take the CPD and tick. But let Aga Khan tell me that the troops that are here are working. Let wherever it is that Simon Kigondu is claiming to be working, tell me that he has been consistently doing this years in the year 2025 in a reliable way. Now on that basis, I free him to continue 2026. It's not happening in 2026. The bottom line is that all evidence says that you must put it practice itself. The actual clinical skill, whether it's nursing, medicine, pharmacy, name it. And don't rely only on the fact that somebody attends meetings.
Thank you, Prof. And that is important. Indeed, you're right, and we are looking at some of those thoughts informing progression in the process of the KMPDC. And one of the roles of the council, again, is review. I think there's an approval role of medical curricula, medical training curricula. I would like you to give us insights on what consideration and thinking goes into that towards the enhancement of quality and safe patient care. No, quality and patient safety training for people being trained into the medical profession.
All core curricula have safety as a big deal in patient safety. But again, nursing side, I've looked at all of them, nursing, the MPDC, now I have another group called oral health. I'm trying to understand what it is that they do. But all of them have that component. Now the point is that how well is it delivered by the institution? Core curricula are very good, they can be very explanatory, very detailed. But now how to monitor the actual delivery of that and make sure that there is a proper practice of that bit, that's where we probably fall short. The curricula are clear, despite the fact that those who are basically removed from us, apparently the Commission for University Education has the single right, but I think we have got them to recognize that they can't do it well, because we realize that the lawyers refused, so we are not capable of refusing a lot. There's a role we have in that. The curricula are well written. The curricula actually are, and they're even enhanced. The one in Aga Khan added things to what the core curriculum does. We have a richer, I didn't have a paper teach my last time I was here, I was young enough to teach actively. There is a lot of that information, but how do we deliver it? And after it's been delivered, when they come out, are we monitoring that they're practicing it well? That's why I'm saying that if you're monitoring CPDs, then you're not monitoring that they're doing it well. If all I'm checking at the end of the year is not including the fact that there's 700 reports on, from this institution that are bordering with safety, then I need to go and find out, can I ascribe them to the institution alone, or do they belong to individuals? But the curricula are fine. The delivery and the actual monitoring of what. You also can teach them well and they go out to practice. And they're practicing well. Again, that's a part where the regulatory bodies are supposed to do to make sure that that is happening. The tools exist elsewhere, we just haven't been adopting them because we follow shortcuts. We just need to create them, use them, modify them for our use.
Okay. Thank you. And Dr. Kigondi, what are your thoughts around the opportunities that exist for collaboration between the medical association or professional associations, the regulators, and those who are right at the patient bedside, like Dr. Wamithi here? And you, yes, I know you're practicing at Kigumo, yes.
Yeah, and Professor has brought out an important thing that has been traditionally what we as a professional medical association have been pushing for. And maybe one of the resolutions from this meeting will be that KMPDC will relinquish that CPD and the monitoring of practice to the association. They are having what is called conflict of interest. They are purporting to regulate because they charge us a lot of money to pay, and then they are also giving the CPD, if you get what I mean. It's only the professional associations in terms of a peer review mechanism that can actually go out and say that this doctor is practicing well. And the association, being an umbrella association, works closely with all others. For instance, it is only the Kenya Pediatric Association that is in a position to actually go and say the developmental pediatrician is actually practicing this, and these are what we are measuring it at. So one of the outputs I would like from this meeting is a very strong recommendation that KMPDC remains with regulation, but with advice from the professional associations on, is Kigondu actually practicing obstetrics and gynecology correctly? And we can come up with those measures and actually give it as a report to the council. The current scenario is that KMPDC is both the regulator, the punisher, the courts, plus the person who is trying, to implement the curriculum. We can leave them to through the curriculum. So please make that recommendation.
Thank you. the sheriff is right here. Now, to Dr. Wamithi, give us an insight into some of the initiatives, and I know you're very passionate about developmental pediatrics. Some of the initiatives locally, I know I've heard about, the chapter contribution and all that. Locally, both within Aga Khan and within your professional association, that are now on the rollout towards enhancement of your presence and impact.
So and thank you, Dr. Kigondu, about talking about the Kenya Pediatric Association. And so we have different courses, and the one that I lead is the Fundamental of Early Childhood Development for healthcare workers. So this is an opportunity for early identification, for knowing the role of the healthcare worker in the referral process, understanding the neurobiology behind brain development and how to mitigate those risk factors. And it's been a collaboration between the American Academy of Pediatrics, the Pediatric Association of Tanzania, and even the Mozambique Association of Pediatrics. And what we've done is, through our collaboration as professionals, we've been able to train 500 healthcare workers. These are nurses, pediatricians, occupational therapists, speech therapists, behavior therapists. Anyone who's a frontline worker, we've been able to train them, and this is in 13 countries. And so that's the impact a pediatric association can do, because we have reach, parents trust us as frontline workers, and so being able to